Assalamualaikum warahmatullahi wabarakatuh. So today will be the last of the 3 lectures that I will be giving to you for year 2 block 3. And before we proceed with this lecture, as usual, I hope that you have taken some time to go over the revision material and revision video provided. So we know that the pituitary gland has both the anterior pituitary and the posterior pituitary. Today's lecture will focus on these hormones produced by both the anterior and the posterior pituitary. Hormones from the anterior pituitary and hypothalamus are subjected to feedback inhibitory regulation by the hormones whose production they control. Feedback regulation is critical for physiological control of thyroid, adrenal cortex, and also gonadal function. And pharmacological treatment that affect these systems are also subject to negative feedback regulation. This is a summary of all the hypothalamic, anterior pituitary hormones and also its target organs and target mediators that are involved. Pharmacological applications of these hormones are usually as replacement therapy for some types of hormone deficiency states, as a diagnostic tool for identifying several endocrine abnormalities, or as antagonists for diseases caused by excess production of certain pituitary hormones. Let's start with the gonadotropins. The gonadotropins consist of LH and FSH. Now, LH and FSH are produced by gonadotroph cells in the pituitary. Natural FSH and LH regulate gonadal function by increasing cyclic AMP in the target gonadal organs. In women, FSH stimulates direct ovarian follicle development, whereas FSH and LH stimulates ovarian steroidogenesis. In men, FSH regulates spermatogenesis, whereas LH stimulates testosterone production. FSH, LH, as well as HCG are all commercially available for treatment of infertility in both male and females. What are the agents involved? Firstly, we have menotropins, or human menopausal gonadotropins, known as HMG. HMG contains FSH-like properties and LH-like substances. It is extracted from the urine of postmenopausal women and has commercially been available since the 1960s. Secondly, we have FSH. There are 3 forms of purified FSH, which has no LH activity. These are urofolitropin, folitropin A, and folitropin B. Both are recombinant FSH. Thirdly, we have LH. Lutropin is a recombinant form of LH, and it is used in combination with folitropin A to stimulate follicular development in infertile women with LH deficiency. Lastly, we have choriogonadotropin alpha, or RHCG. RHCG is produced by the placenta and extracted from urine. What are the clinical uses of these synthetic gonadotropins? Firstly, for induction of ovulation. They induce ovulation in patients with hypogonadotropic hypogonadism, such as in patients with polycystic ovarian syndrome or obese patients that are not responding to clomiphene treatment for infertility. They are also used during controlled ovarian hyperstimulation in assisted reproductive technology procedures, such as IUI or IVF. These synthetic gonadotrophins are also used to treat male infertility. In men with signs and symptoms of hypogonadism or delayed puberty, they can be used as treatment. Alternatively, exogenous androgen can also be used. For treatment of infertility, we can use both synthetic LH as well as synthetic FSH. What are some toxicities and contraindications that we have to be aware of when treating patients? Firstly, and most commonly, is ovarian hyperstimulation syndrome. This occurs in 0.5 to 4% of patients receiving synthetic gonadotrophins. It is characterized by HMG-induced ovarian enlargement, ascites, hydrothorax, hypovolemic shock, hemoperitoneum from a ruptured ovarian cyst, fever, or arterial thromboembolism. So when giving these synthetic gonadotrophins, we have to be aware of this complication. It can also cause multiple pregnancies, headache, depression, edema, precocious puberty, antibody production to HCG. In men, they might have breast enlargement or gynecomastia. Next, we will discuss gonadotropin releasing hormones or GnRH and its analogs. Gonadotropin releasing hormone or GnRH is the key regulator of the reproductive axis. Its pulsatile secretion determines the pattern of secretion of the gonadotropin's follicle stimulating hormone FSH and luteinizing hormone LH, which then regulate both the endocrine function and the gamete maturation of the gonads. GnRH is secreted by neurons in the hypothalamus, and it binds to the G protein coupled receptors on the membranes of the gonadotroph cells. There are two types of release of GnRH, namely pulsatile GnRH release, which stimulates the gonadotroph cells to produce and release LH and FSH. This is its gonadal stimulation activity. There is also sustained non-pulsatile release of GnRH. This inhibits the release of FSH and LH by the pituitary and causes hypogonadism. So this leads to a gonadal suppression activity. So you have to remember that GnRH has both gonadal stimulation activity and also gonadal suppression activity. And what determines which type of activity it is the type of release of the GnRH itself, whether it is pulsatile release or sustained release. What are the synthetic forms of GnRH? The synthetic forms have a more potent and long-lasting effect compared to the native GnRH. So you have gonadorelin, which is a synthetic human GnRH. You have gosirelin, historelin, nafarelin, triptorelin, and luprolide. So you can see the pattern here. What are the clinical uses of GnRH analogs? We have firstly, according to its stimulation of the hypothalamic pituitary gonadal axis, we can use it to treat female infertility. So GnRH analogs will precipitate the LH surge and initiate ovulation. For treatment of female infertility, there are three common ways. Firstly, we give gonadotrophins, FSH or LH. We can also give pulsatile GnRH, but less commonly. And we can use assisted reproductive technology. And sometimes these treatment modalities are used in combination. Secondly, for treatment of male infertility. So for treatment of male infertility, we will use pulsatile gonadorelin in men with hypothalamic hypogonadism. So pulsatile intravenous administration is given every 90 minutes via a pump, and this will stimulate FSH and LH release. GnRH analogs are also used to diagnose LH responsiveness. In patients with delayed puberty, we want to figure out whether the cause is due to constitutional delay or hypogonadotrophic hypogonadism. So how do we do the test? We give an intravenous or subcutaneous GnRH bolus, and we measure the LH levels. So how do we interpret the results? In patients who have an increase in LH levels after given the bolus of GnRH with a peak of more than 15.6 milliunits per mil, their delayed puberty is due to a constitutional delay. In patients with impaired response, or there is no increase in LH levels, this is due to hypogonadotrophic hypogonadism. Secondly, we can use GnRH analogs in its second function, that is to suppress the hypothalamic pituitary gonadal axis. So this is used to control ovarian hyperstimulation during assisted reproductive therapy such as IVF. So what it does is we use leuprolide and nafarelin to suppress the endogenous LH surge that can trigger premature ovulation in IVF treatment. Because we want the ovulation to be on time. Then in patients with endometriosis. Now, endometriosis is due to estrogen-sensitive endometrial tissue, which is outside of the uterus. GnRH analogs are used to reduce estrogen and progesterone and prevent the cyclical change. The agents used are usually leuprolide, goserelin, and nafarelin. However, we cannot use GnRH analogs for more than 6 months because one of the side effects of GnRH analogs is decreased bone density. And why is decreased bone density a problem? Because this leads to osteoporosis, and osteoporosis will put the patient at susceptibility to have pathological fractures. Then we can also use GnRH in the treatment of fibroids. Now, fibroids are benign and estrogen sensitive. However, they can cause menorrhagia and pain during menstruation. So the agents we can use are leuprolide, goserelin, and nafarelin. For patients with prostate cancer, we can also use GnRH analogs in combination with anti-androgens. Leuprolide, goserelin, histrelin, and triptorelin are the preferred GnRH analogs. Initially, there will be an increase in testosterone production. This is due to the agonist action However, after a while, the serum testosterone will drop. In patients with central precocious puberty, we can use leuprolide or nephrolin. However, it's important that proper pre-treatment evaluation is performed on the patient before starting the treatment. Okay. Other than that, GnRH analogs can also be used to treat advanced breast and ovarian cancer. This is because GnRH agonists have been shown to be as effective therapeutically as surgical ovarian ablation in pre- and perimenopausal women with advanced breast cancer. The combination of GnRH agonists such as goserelin with the peripheral estrogen antagonist tamoxifen can be used to produce combined estrogen blockade. What are some adverse effects? Namely, headache, lightheadedness, nausea, flushing, hypersensitive dermatitis. In women, it often presents as the typical symptoms of menopause. They can also get ovarian cysts or osteoporosis. Okay, now we will discuss GnRH receptor antagonists. These include drugs such as ganirelix, cetrorelix, aberrelix, and digarelix. And you can also see the pattern in the naming of the drugs here. These GnRH antagonists are used to prevent LH surge during controlled ovarian stimulation in assisted reproductive therapy, and they also are used in advanced prostate cancer. This sounds familiar, right? Because it seems to have the same effects as non-pulsatile GnRH agonists. Okay, so when you compare non-pulsatile GnRH agonists with GnRH antagonists, okay, what is the difference? Okay, for GnRH antagonists, there is immediate antagonism, so the duration of administration is shorter, and the effects can be reversed more quickly. So you have more adherence to the therapy. There is also less side effects and is generally more well tolerated. So what are the drawbacks of GnRH antagonists? It inhibits the LH production, so it inhibits steroidogenesis, and this can impair FSH production, and you need to supplement the FSH during the follicular phase. Now we will talk about growth hormones. Growth hormone or somatotropin is a 191 amino acid polypeptide. It's required in childhood and adolescence for us to attain normal adult size. It's also essential in lipid and carbohydrate metabolism and for the body to develop lean body mass. The actions are via IGF-1 or somatomedin and IGF-2, which is a minor component, and both are produced by the liver. The effects of growth hormone is growth at our epiphysis, for lipolysis, and the growth of skeletal muscles. Growth hormone used to be harvested from cadaveric source, but this is no longer used because of Creutzfeldt-Jakob disease, or also known as mad cow disease. So now we have recombinant human growth hormone, and two types which are equipotent with native growth hormone, known as somatropin and somatrem. Endogenous growth hormone has a T-half of around 20 to 25 minutes. Recombinant human growth hormone is given subcutaneously around 3 to 6 times per week. Peak levels will be in around 2 to 4 hours, and it will persist for approximately 36 hours. Long-acting preparation of somatoprin degrades slowly and takes around 1 month to be fully released. Somatotropin is equipotent with the native pituitary hormone, and the effect is via cell surface receptor or JAK and STAT cytokine receptor. Now, I hope everybody has read the handout so they know exactly what we are talking about. And then the effects are through the growth promoting effect via IGF-1 from the liver, and it also stimulates IGF-1 production in bone, cartilage, muscle, and kidney. In longitudinal bone, the growth is stimulated until the epiphysis closes, and it has an anabolic effect in muscles, a catabolic effect in lipid cells. There is also a shift of body mass to increase of muscles and reduce central obesity. The effect on carbohydrate metabolism is mixed. Growth hormone deficiency in children are either genetic or acquired. The incidence of congenital growth hormone deficiency is around 1 to 4,000 live births, and they usually present with short stature and adiposity and also hypoglycemia due to the unopposed hyperinsulinemia. And patients with growth hormone treatment due to short stature, the use of recombinant human growth hormone will permit many children with short stature to achieve normal adult height. In adults, when they have adult onset of growth hormone deficiency, either due to damage to the hypothalamus or due to a pituitary tumor or secondary to radiation, they will present with generalized obesity, reduced muscle mass, asthenia, reduce in cardiac output. And once treated with growth hormone analogs, they will have increase in lean body mass, increase in bone density. There will be an increase in exercise tolerance and a general improvement in the sense of well-being. However, adverse effects can include arthralgia and fluid retention. Other clinical uses of growth hormone analogs other than growth hormone deficiency include Prader-Willi syndrome, Turner syndrome, wasting in patients with AIDS. We use the anabolic effects, and also in patients with chronic renal failure in pediatric patients, and short bowel syndrome in patients on specialized nutritional support. So the more detailed explanation of these syndromes can be found in your notes. Okay. So toxicity, Creutzfeldt-Jacobs disease was a fatal side effect from growth hormone taken from human cadaver. So that's why we stopped the usage of these types of growth hormone in 1985. And this toxicity is not associated with recombinant growth hormone. In children, there are several adverse effects, namely intracranial hypertension, which can cause vision changes, headaches, nausea, vomiting. The children can get scoliosis because of rapid growth. can also have otitis media in patients with Turner syndrome, and hypothyroidism, pancreatitis, gynecomastia in male children, and also nevus growth or increase in the growth of melanocytic nevi, such as these. Next, we go on to growth hormone antagonists. Growth hormone antagonists include octreotide, pegvisomant, and bromocriptine. So, clinical uses of octreotide include for hormone-secreting tumors such as pituitary adenomas, and which causes acromegaly in adults and gigantism in children. It's also used for the acute control of bleeding from esophageal varices. And adverse reactions to growth hormone antagonists include nausea, vomiting. Next, we come to prolactin and dopamine agonists. Prolactin is the principal hormone responsible for lactation. A deficiency of prolactin is rare, and it causes failure to lactate and a luteal phase defect. There is no current treatment for this deficiency. In patients with hyperprolactinemia, it's either due to hypothalamic destruction or prolactin secreting tumors, and it causes galactorrhea and hypogonadism. And we treat it with dopamine agonists. Dopamine agonists, firstly, dopamine is released by the hypothalamus to inhibit prolactin secretion from the anterior pituitary. Dopamine receptor agonists are ergot derivatives such as bromocriptine, cabergoline, and pergolide. A more detailed explanation as to what ergot alkaloids are in your notes, and non-ergot derivative of a D2 agonist is quinagolide. So dopamine agonists will decrease the pituitary prolactin secretion through dopamine mimetic actions on the pituitary. They act directly on pituitary dopamine receptors to inhibit prolactin release. Dopamine agonists are used for treating prolactin-secreting adenomas to reduce the tumor size and also serum prolactin levels. They're used to treat amenorrhea and galactorrhea in women. Okay, now we will talk about the posterior pituitary hormones. Firstly, oxytocin, which is a peptide hormone. It elicits milk injection in lactating women. It contributes to the initiation of labor and is released during sexual orgasm. It can be administered intravenously for stimulation of labor, and it's also given via nasal spray to induce lactation postpartum. Oxytocin alters the transmembrane ionic currents in myometrial smooth muscle cells to produce uterine contraction. It also causes the contraction of myoepithelial cells surrounding the mammary alveoli, which leads to milk ejection. Clinically, oxytocin is used as a standardized oxytocin challenge test to provide information on the placental circulatory reserve. Secondly, is used to induce labor and augment dysfunctional labor. And thirdly, it's used to control postpartum hemorrhage. Usually, serious toxicity to oxytocin is rare. However, there have been reported cases of maternal death due to hypertensive episodes, uterine rupture, water intoxication due to the activation of vasopressin receptor, which leads to excessive fluid retention, and also fetal death. Next, we go to vasopressin or ADH. So vasopressin has an antidiuretic effect and a vasopressor effect. It binds to V1, which causes the vasoconstriction, and V2, which causes the antidiuresis. The routes of administration includes intravenously, intramuscular, and also intranasal. The synthetic analog is desmopressin, which is a long-acting synthetic analog. If we want to compare desmopressin and vasopressin, or ADH, desmopressin has more of antidiuretic effect and less pressor effect. So when we compare the pressor effect, ADH is 4,000 times more potent than desmopressin. Clinically, vasopressin is used in the treatment for pituitary diabetes insipidus, in some cases of esophageal bleeding, and in colonic diverticular bleeding. It can also be used in aqueous vasopressin form or desmopressin acetate and felipressin. Okay, vasopressin, not desmopressin, causes vasoconstriction. So it has to be used in caution with patients who have coronary artery disease. And the nasal preparation of vasopressin or desmopressin can have less effective results if you have nasal congestion. Vasopressin antagonists which are available are conivaptan and tolvaptan. So these are used in hyponatremia, acute heart failure, which is associated with elevated vasopressin. Okay. And we have come to the end of our third and final lecture. So once again, you've all worked very hard today. Congratulate yourselves. Take some time to understand and remember all these facts and concepts, and have a great day.